So, you touched on MRD. I think that's really important in practice. Well, first of all, I guess before we talk about practice, can we talk a little bit about methodology? What are the methods used? Which, in your opinion, is best? What's the sensitivity cutoff? Which compartment? I have lots of questions about MRD. And what do you do in your own center?
Sure. So MRD in CLL is kind of an emerging, kind of evolving kind of topic. It's not quite there as it is in the acute leukemias. And as previously mentioned, the basic modalities that we use are flow cytometry or by PCR, which will get you to that 1 in 10,000 level.
What about even deeper? So my general impression is that flow generally can do 1 to 10 to the minus fourth, ASO PCR or NGS maybe fifth or even sixth. I guess the question is, do we need to go that deep? Does anyone have a feeling one way or the other?
So I don't think there are any data yet that support that going that deep at 10 raised to minus 5 or 10 raised to minus 6 is associated with outcomes. So yes, obviously there will be data that show that a smaller proportion of patients will reach that threshold at 10 raised to minus 5 or 10 raised to minus 6. But I think we need more data with longer follow-up to actually make clinical decisions based on those technologies. The other thing, as you pointed out, is important to understand that there are at least 3 different compartments in CLL where disease can be measured, the peripheral blood, lymph nodes, and the bone marrow. And I think all that we are able to do now is the peripheral blood and the bone marrow. And a lot of disease may be present or may be residual in the lymph nodes. And I think that also needs to be taken into account as we interpret the data that come out from MRD testing.
So I think you said it perfectly. The depth of response is a justification for why we could stop at 12 months. Does anyone think that we need to actually check it in practice, given that we're going to stop everybody at 12 months based on the way that this drug has been labeled?
So if you look at the progression-free survival based on the MRD status, so everybody, remember on the study, everybody stopped after 12 months of treatment. Some patients, about 57% of patients achieve an MRD negative status in the bone marrow, whereas the rest of the patient did not. When you look at their progression-free survival, those who has MRD negative response has a significantly prolonged progression-free survival. Well, it may not be practical for the community practice yet, but I think in all of the clinical trials nowadays, when you're using venetoclax-based therapy, MRD is a very, very important endpoint because it seemed to be a really good surrogate marker to predict the long-term clinical outcome.
But I think you're right that in clinical practice, if you have finished 12 cycles of therapy with venetoclax and obinutuzumab in the frontline setting, regardless of what your MRD level is at that point, you're not going to make any changes to your treatment plan. It will be important from a prognosis standpoint where you could counsel patients as to how quickly is it likely that their disease is going to come back versus someone who's MRD negative at the end of 12 months of fixed duration therapy.
But I think there are also, that's becoming the next clinical trial question is to maybe we should design studies that are, the endpoint is not a fixed duration, but it's rather more your goal is to achieve MRD negative state. So to tailor your treatment based on the MRD. So that would be the kind of one of the future directions for clinical trial.
So at ASH this year, the CAPTIVATE trial was presented in sort of its earliest form in terms of the data available. Do you want to highlight that study and how decisions could be made based on MRD?
So the CAPTIVATE study is a study that uses 2 of our best agents for CLL up front, a combination of ibrutinib and venetoclax. And this study was done where they enrolled 164 patients, where similar to the CLL14 study, there was a phase in the first 3 months where single agent ibrutinib actually in this study was used to debulk, quote unquote, the patients to prevent the risk of tumor lysis syndrome that can happen with venetoclax ramp up. And then patients received venetoclax starting month number 4. And then this was a fixed duration study, therapy, for 12 months. And then patients were randomly allocated depending on what their MRD status was. If they were MRD negative at the end of 12 months, they could get randomized to either placebo or continuing ibrutinib for the next 12 months. versus if they did not have any detectable MRD, was not confirmed, meaning they were MRD positive, then they would get randomized to either ibrutinib or the combination of ibrutinib and venetoclax. And I think early results from this study suggest that patients who continue with this therapy for the combination for a year have a MRD negative rate of anywhere between 70 to 75%, both in the peripheral blood and the bone marrow, which interestingly is very similar to venetoclax and obinutuzumab in the frontline setting. And I think longer data for the randomization that occurs after the 1-year time point are still not available, and those would be interesting results to follow up on.